So we are now going to shift gears still in the genitourinary realm by Kim Rathmell. Thanks.
Okay, I also want to thank the organizers for that opportunity to talk about some of the work in kidney cancer, and also for organizing the sessions such that we come a little bit later. Kidney cancer has been a little bit late to develop, and so you've already been prepped for some of the things that I'm going to talk about. So first, kidney cancer, like pancreatic cancer, has been on the rise. And although this is a somewhat dated slide, you can see that dating back to the 70s, we've been seeing a steady increase in this cancer. And so although it was originally characterized as a rare tumor type, it really is not anymore. And this talk will focus on one subtype of kidney cancer. That's clear cell histology renal cell carcinoma. This is a histology slide showing why it's called clear cell. It has these cells with cleared cytoplasm. This tumor is characterized by a particular mutation, and that's mutation in the von Hippel-Lindau gene, coordinate with loss of chromosome 3p, where VHL is housed. We see these mutations and loss of 3p, which houses other tumor suppressors as well, in up to 90% of these tumors. And based on this strong correlation between clear cell type renal cell carcinoma and the VHL mutation, our tumor type has a very distinct paradigm in which VHL loss causes upregulation of hypoxia-inducible factors, and these tumors are characterized by high levels of these HIF factors. These are transcription factors that normally allow cells to respond to low levels of oxygen by turning on a repertoire of genes that allow them to bring in new blood vessels, to shift their metabolic properties, to migrate away, to promote survival and de-differentiate. And so that's a perfect storm for kidney cancer in some respects. Because this cancer has been highly unresponsive to chemotherapy, there's been much effort in recent years on developing targeted agents. And these targeted agents, to date, all focus on this well-known pathway in clear cell type renal cell carcinoma. Most of the agents focus far down on this pathway, targeting the receptors of VEGF and PDGF. These are tyrosine kinase inhibitors that are effective at reducing the tumor angiogenic profile and can be quite effective at reducing the bulk of these diseases. Other drugs similarly target this pathway, for example, targeting features of the tumor that enable HIF to be stabilized, such as the mTOR pathway, so that temsirolimus, everolimus are approved drugs that we use. And there are in development drugs targeting MET, which is another mutation that can occur in this cancer and similarly increases HIF levels. But the reality of treating kidney cancer is that the available drugs that we have do not produce complete responses. We only work in the arena of minimal response and partial response. The extent of response that a patient will get is unpredictable. The duration is also unpredictable, and the toxicity is unpredictable. And for drugs that we expect to be effective on average for 1 to 2 years, this is chronic therapy, it's very expensive, and it's dominated by effects that are substantially detrimental to quality of life: fatigue, rash, diarrhea, as well as laboratory abnormalities that indicate damage to the liver or elevations in glucose and cholesterol. So with that, I'll talk about various molecular probes that we use to understand some of the diversity or the heterogeneity across the clear cell renal cell carcinoma spectrum. So before I really dive into clear cell renal cell carcinoma, I do have to point out that there are other histologies of this tumor as well. So when we say kidney cancer, we're talking about a big spectrum. Clear cell renal cell carcinoma is that's tied very closely to von Hippel-Lindau disease and loss of 3p, and it's about 70% of all the cases that we encounter of tumors in the kidney. But there are also other types: papillary type renal cell carcinoma, chromophobe, a benign tumor oncocytoma, a translocation carcinoma, and some other very rare types. And these types of tumors, we really have very little in terms of knowledge of how to treat these patients, and their genetics are highly distinct from clear cell type renal cell carcinoma. So someday in the future, we'll understand not only how to treat our clear cell renal cell carcinoma patients, but have effective molecular information to target these cancers as well. So clear cell type renal cell carcinoma has been well known to be molecularly heterogeneous for some time. This is a gene expression profile. Oh,
Too tall.
I'm too tall for this mic, sorry.
Fits me.
Can you hear me now?
Yeah.
Okay, I'll try not to drift away. So, so you've already seen heat maps from several of these other talks looking at gene expression profiles, and as you can see, the gene expression profile across a large group of tumors here suggests that there are great areas of variability, with at least 2 and maybe as many as 5 groups based on gene expression purely. So our group undertook at the time, developing pattern recognition profile, which is now in fairly routine use, to try to see with a more robust computational strategy what subtypes we could really identify, that we could really pin down and understand with genetic profiles. And we found 2. For lack of better knowledge, we call them clear cell A and clear cell B, CCA and CCB. So these are very distinct biologically. And when we looked at these tumors in terms of their outcome, they also have significant prognostic relevance, with the clear cell A tumors in this original cohort having a median survival of 103 months compared to the 24 months for CCB tumors. The TCGA, which has been discussed here in many of the previous talks, was a great source for validation. We assigned these tumors to clear cell A and clear cell B group subtypes and looked at survival, validating our previous results, with the clear cell A tumors having a much better survival profile than those clear cell B tumors. And so this classification scheme, which is based on somewhere between 34 and 120 gene signature, can classify robust subdivisions of clear cell type renal cell carcinoma and can be applied with a small number of genes to individual tumors and independently associates with disease-specific and overall survival, making it a valuable prognostic biomarker. Now, we used these profiles then to understand a little bit more about the rare variant groups. This is still in the clear cell renal cell carcinoma arena, but when we took a very large group of compiled tumors, this was a meta-analysis of over 500 tumors, all histologically defined as clear cell type renal cell carcinoma, and we applied our expression pattern recognition algorithm. Of course, when we asked for 2 groups, we found 2, and they correlated with our clear cell A and clear cell B. But when we ask for 3 groups, we can find a small group that now filters out, now that we have the power in numbers, to identify what we called cluster 3. So what is in cluster 3? So cluster 3, as I said, are histologically defined clear cell renal cell carcinomas. But when we look at their gene expression profile, it's very different, particularly with regard to metabolic properties. And we see upregulation of genes that are involved in mitochondrial regulation and oxidative phosphorylation, suggesting a striking difference in the way these cells, or these tumors, likely regulate metabolism. In addition, now these are tumors that we can't go back and genotype for von Hippel-Lindau mutation or loss of chromosome 3p. But the loss of VHL regulation leads to characteristic changes in the gene expression profile. And so when we use those gene expression changes to predict whether these tumors have an intact VHL or a mutant VHL, wild-type VHL here, the wild-type VHL signature here is shown in purple. And you can see that these purple tumors, the wild-type VHL tumors, all tightly cluster with cluster 3. So these are probably not clear cell renal cell carcinomas, although many, many pathologists call them that. So we pulled them out and said, did they look a little bit different? And my graduate student who did this work came right away and said there's something funky about these clear cell renal cell carcinomas that we call cluster 3. As you can see in the top, these are a clear cell A and a clear cell B tumor. They all have the clear cytoplasm, and really what we've seen is that they're not distinct histologically, although they're very different molecularly, and as I've shown, have a very different prognostic outcome. But the cluster 3 tumors, although the cells themselves might have cleared cytoplasm that gave them the clear cell histology designation, they have a very different pattern of organization with a papillary type of feature. And so what we think that we've identified is a new rare variant of clear cell renal cell carcinoma that simultaneously another group of pathologists identified and called clear cell papillary type renal cell carcinoma. And that suggests that really we need to take great care when we treat these patients, because what we have is clear cell type renal cell carcinoma, most of which are VHL mutated. We do have clear cell and clear cell B. These are the tumors we should be treating with these drugs that we've identified based on the effect of the pathway that's activated by loss of VHL. But clear cell papillary renal cell carcinomas probably won't respond very well because they are VHL wild type, just like papillary type renal cell carcinomas don't respond well either. So to summarize this section, clear cell renal cell carcinoma can be separated into two groups, A and B, based on transcript profiling, but that further clustering can identify biologically highly dissimilar subtypes within the clear cell group. And that subtyping can convey biological distinction as a valuable tool for prognostic evaluation and a likely cause for some of our poor responses to therapy. Okay. My title, I indicated that we would also turn to clinical trials for helping us understand clear cell renal cell carcinoma a little bit more. A clinical trial that we completed some years ago, LCC 0603, was a neoadjuvant clinical trial that looked at the treatment of renal tumors with Sorafenib. Patients were identified as having a renal tumor and underwent a CT scan for basic size description and a PET scan. And then were treated with Sorafenib. This is the first generation VEGF receptor tyrosine kinase inhibitor for 4 to 8 weeks, and then underwent a post-treatment CT scan and PET scan, and then their nephrectomy. We're going to look at radiographic indicators of response rather than molecular indicators. So first, standard RECIST criteria indicated that we do see partial responses. Again, there are no complete responses here. Many patients had subpartial responses or minimal responses. Their tumors shrank but didn't meet this standard criteria of 30% decrease in longest size. Some tumors actually grew. Now, what we realized as we looked at these tumors is that we probably need new ways to describe response. The standard RECIST criteria response is really just based on longest diameter and measuring this in comparison after treatment. And I'll actually use this particular patient as the example. Here in the pre-treatment, we have a very large renal tumor. Post-treatment, this tumor was still very large. In fact, measured slightly larger than it had been before. But if you look at this tumor, it's very different. The central area of this tumor is now very dark, indicating necrosis is what we think. But we took these tumors out, and we can confirm that these dark areas are very necrotic. And so we developed a new way to try to quantify the area of tumor that's actually killed in response to this treatment. Similarly, we were doing PET scans on these patients. And we were doing that because we were trying to understand how the metabolic properties of these tumors might indicate how these patients would likely respond to this treatment. We see and have known that there are some tumors that are very dim on FDG PET. So this is a tumor. You can see it here. It's barely visible on the PET scan that doesn't take up any FDG. So this tumor has a metabolic profile that is not dependent on uptake of glucose. Other tumors, for example, this tumor, have regional areas that can be very high in terms of FDG uptake. And when we looked at these tumors, we discovered first that the non-clear cell histology tumors were much more likely to have high levels of FDG uptake. So metabolically active tumors were more likely in the clear cell group compared to in the non-clear cell group. This is the papillary chromophobes and probably the papillary clear cell types than the clear cell group. Secondly, we discovered that the correlation between FDG uptake and response was somewhat different than what we might have expected. We might have expected that the more metabolically active tumors would be those that would respond better to an angiogenically targeted agent. But in fact, the opposite was true. The best responders were those that had very low levels of FDG uptake. And so we're still trying to understand exactly what that means. Certainly that means that those clear cell tumors are the ones most likely to respond, which is what we've known, and those are the ones with the lower levels of FDG activity. But we continue to try to understand the metabolic properties of the tumors that make them different and more likely to respond. And so that leads to our next clinical trial. This is now ongoing. This is LCC 1028. It's a neoadjuvant clinical trial using the newest generation. Well, they're coming out so fast, actually, it's not the newest anymore, but the next to newest VEGF receptor tyrosine kinase inhibitor. Patients now are getting a CT scan and a biopsy to confirm, in fact, that they would be clear cell type renal cell carcinoma, and as well to allow us to do molecular studies that directly measure their metabolic activity and other effects. They're being treated for 8 weeks with another CT scan, undergoing nephrectomy. And we will then be able to look at clear cell variant histology. They'll all be clear cell going in, but there may be variants included, as well as looking at their VHL mutation and other mutational status, their transcript profile, in particular the clear cell A and clear cell B group, and other protein expression signatures. And then finally, looking at molecular and genetic contributions to intratumoral heterogeneity. I've told you that encountering a group of patients with clear cell renal cell carcinoma is a big heterogeneous group in terms of the histology and their molecular differences. But it turns out that when you dig down into the tumor, those tumors are heterogeneous too. So this is, of course, known for all tumors, that if you sample in multiple different places, the histology will look different. And in fact, the grade can be different depending on where you sample. So what does that mean molecularly? Well, a group at the Sanger Center published on a small number of tumors that when they sequenced these tumors, they find that while there are some mutations that are ubiquitous, meaning the mutation is found in all samples across the primary tumor and in the metastatic tumor, that there are mutations that are private. There are mutations that are common only among the primary samples, and there are mutations that are common only among the metastases, and there are a lot of mutations that are unique to the individual sample. And so this makes a whole new level of complication as we move toward personalized therapy, in particular therapy that's based on biopsy metrics. This group actually looked at our clear cell A and clear cell B group subtypes. And what they saw when they looked at 6 samples from the primary tumor was that in 5 of the 6 samples, the gene signature indicated that these would be clear cell B type tumors. So depending on your glass half full or glass half empty, the glass half full version of this would be that 5 out of 6 times they picked that this patient would have poor outcome. And this patient has metastatic disease, so in fact that's true. The glass half empty would be that 1 out of 6 times you would pick wrong, and this patient would have been indicated to be a clear cell A type tumor, and you might have predicted that this patient would do well and in fact be wrong. So it helps us understand sort of the limitations of this test. But it also gives us an opportunity to understand a little bit more about these tumors. And so for the future, a trial that we've really just initiated is uniting some of these imaging observations that we've made with tumor genetics. So we'll be taking patients, and this is patient number 1. Patient number 2 just had his MRI last week, and doing an MR in coordination with a PET scan so that we can get a detailed look at these patients' tissue perfusion and vascularity and the density of these tumors, as well as regional areas of FDG uptake, and sample according to the map that's created by the imaging, as well as samples that are collected based on what we see grossly in the tumor. Here you can see a sample that we collected from a region that's highly distinct from the mostly more pale yellow regions of the tumor. Now this has just begun, so I can't tell you how well we're going to be able to correlate the gene expression and genetic underpinnings between what we see on the tumor and what we see in the MR PET, but it will help us to be able to move forward. So To summarize, there are multiple ways for renal cell carcinoma to diverge. The subtypes can enrich tumor sets for clinical and genetic features, and a multi-platform approach with genetics, molecular biology, and imaging will give us many ways to tackle what's surprisingly a very heterogeneous disease.